All right, welcome Tuesday, folks, and welcome Monday, folks. And you can see some of us are here and today, and glad that you guys are here. We talked a little bit about Florence and a few things that are going to be considered different. Obviously, the biggest one is that life is not the same. We'll always remember this very unusual circumstance that we found ourselves in. And in many ways, as you get older, you'll remember about the time that you evacuated or didn't, and so forth, so on. I share with some of the stories with these folks, but I'll share one more. That one night, right towards the end of the hurricane, I left the house during the imposed curfew to look for gasoline, and I was able to find it, and I put it on Facebook. But we all going to go ahead and do our best and take it from there. One of the things we're going to do is, let's see if we can stick with the original 5:30 to 8, if that's feasible. If not, we'll do 6 to 9 if that's not possible. But if we can do 2.5 hours like we've been doing, and then let's add 2 more things and make them mandatory. One is a visit to the free clinic, and I'll give you several options for that. That's on a Wednesday night. And then we'll visit my prior practice. Maybe we'll do it another evening as well. Make those visits more like an hour and a half or something like that, maybe 2 hours at the most. And that way you'll see the real deal, how things go. If we go to the free clinic, we'll probably have the opportunity to talk to some patients. When we do it at the prior practice, we'll talk to the person who does the billing, the scheduling, and so forth, so you can get a better understanding of how is it that we basically run the business of neuropsychology. We've also discussed before we start recording that we will have an attendance policy that from next Monday on, or excuse me, next Tuesday on, we will require you to miss no more than 2 classes. If you miss 2 classes because you don't have a reasonable excuse, then we drop 1 letter grade, and that would include the extra things that we're doing. We'll drop down the number of pages of the paper to 12 pages, and then we'll probably talk a little bit about, what is it that you're going to do? Because one of the things that really, I know sounds very corny, but we should state it, you got to do something. You got to do a project, because this is basically what your grade that you've decided, and we don't have much time. This is basically, we are having fall semester, second version, and this second version is only 8 weeks long. So whatever happened in Vegas stays in Vegas. And that was the early part of the semester. And now we're going to go to the second part of the semester. So it's in some ways maybe kind of like a new class. So we'll put the revised syllabus on the website. I thought the last one that I did should have been on, and when I printed it earlier, it turns out it wasn't. So apologies, but we'll revise it again. And we'll call this one proposed revision so we can discuss and make sure that everybody's on board with it. And if everybody is on Tuesday, we'll just move on and make sure that that's what we all have agreed to. So enough for the basic stuff. Now let's get on to it. Essentially what we're going to do as the semester wears on, if you look at the syllabus, we have roughly 16 lectures or some variation of theme left. We're going to go ahead and do 2 a night, but I also want to make sure that we spend some time doing some practical things. I don't want to necessarily just be a regular old I talk and you listen, although I hope that we have a lot more interaction than even a typical class when I'll lecture. But I think what we might do is we might have 1 hour plus of the first lecture, take a 5-minute break, literally, do another 1 hour plus maybe another 5 minutes, and then maybe 30, 45 minutes or so more of more practical kinds of things. And if we do the practical things, we might end up doing them in the lab where we have a lot of the test equipment, and that way we can use that 5-10 minute break literally to go up the stairs. So this is what I'm going to propose on the syllabus, and we'll discuss it next time that we meet. We left off last time on theoretical perspectives. We had discussed historical perspectives, and I want to go a little bit more with the theoretical perspectives, and I want to sort of tie them in a little bit to the historical perspective before we move on to the practice and profession of clinical neuropsychology. In terms of the theoretical perspectives, you were discussing with me before we really got it rolling, that we had discussion of how is it that we understand whether something is abnormal or not. And just to make sure that we kind of put it, again, within the boundaries of what we discussed and how we should think of it, let's make it even simpler in case you've forgotten some of those things. That what we do is we administer tests to people, and we try to figure out whether the performance on that test is impaired. Now, how do we do that? First of all, we develop a theoretical perspective of what is it that we're interested in measuring. Let's take something really relatively simple, like, for example, memory. I want to determine whether you have short-term memory deficits. So I look at the literature, come up with an idea of what may be a good definition of short-term memory. For example, that you can't learn or you forget quickly. And then I look at what other people have done to measure short-term memory, and then I develop, for example, a list of words like house, tree, cat, boat, book. And then I read that or say it to a patient and see how many do they get. The thing that's important here is that every time that we give a test, that test is administered in the same way, using the same administration, because I can't give you a test and then somebody else I give a slightly different version of that test, or even a slightly different version of specific instructions. I want to make sure that everything is the same, because what I want to do is I want to compare you to other people. Now, let's take the case again of memory. I've given you a list of 5 words, and I want to find out whether you have some impairment. How do I know that you have impairment? Well, I have to compare you. I remember when I was in grad school telling my mom that I gotten a B in one of my grad school courses, and she seemed proud as I was. And I failed to tell her right away, and although eventually I shared with her, there was 13 people in the class, and I got the 13th lowest grade in the class. So a B is of no value, When you're 13 out of 13, you're clearly in bad shape. So you want to compare yourself to a group of people, but the goal is to make sure that you compare yourself to people that they're worth comparing to. So, for example, one thing I might do is I might give that list of words to a bunch of people that don't have brain damage and see how they do. Or alternatively, I may want to give it to people that have brain damage. But maybe I want to go a little step further. I want to give it to people that have a certain kind of brain damage. For example, if you have Alzheimer's, you should expect a certain kind of memory loss. If you have traumatic brain injury, you might expect a different kind of brain disorder, or if you will, short-term memory deficit. So you want to compare the scores, not only to like normal people, but specific groups of people that have specific kinds of problems. Now, I'm not going to get too much into it, because this in itself is very complicated and fascinating as well. That is how you compare it. And I'll share the story that one time my wife was really bummed out, saying that we don't go to nice vacations. And I said, why is that? It's because Agnogs that live next door typically go to Europe and Tuscany for a month at a time. I said, well, the difference is that the average American goes to, Myrtle Beach for vacation, and very rarely do people go to Tuscany. So if I compare myself to people who go to Tuscany, I'm going to look like a pauper. I've got to find out what is the average vacation of people in the U.S. Well, the average vacation is 1 week to Myrtle Beach. Well, that's what I need to compare myself to. I can't compare myself to people that go to Tuscany, because then my results are going to be of little value. You have to be really, really careful. And this turns out to be a huge problem, because most tests are what we call normed. They're standardized using what I call samples of convenience. Well, you guys are excellent examples of samples of convenience. What do I mean by that, Christy?
You sample conveniently, so you just kind of grab the people that you could easiest.
From general psychology class. Now, realize that only 2/3, 3/4 of the population have high school degrees in North Carolina. And if you add undocumented people, it drops down a little bit. So the fact that we're testing freshmen is bad, because they're not reflective of the world. We're the second or third hardest school to get into the UNC system. So we're going to get really good students that attend college. That's not reflective of the population at large. So we got to be really, really thoughtful of what is it that we are comparing people to. The other thing that's important is that when you're doing that comparison, I want to emphasize that you can't just like do one test. Why do you do more than one test? Because it could be that that day or that moment or that test, the patient didn't do so well. So you might want to do 2 or 3 tests. So think of it as like laser. You want to measure verbal memory, and then you want to measure visual memory, and then you want to do a test that measures both memory. And then what you want is to have some kind of, how do I say, something that sort of comes across as solidified. There's a unified theory or unified set of symptoms that come out on these tests. So essentially what we do is we administer tests in a scientific, empirical way, compare the findings that you get from to other people that have had brain damage or some variation of the theme, and we do 2 or 3 versions of that to make sure that we come up with, if you will, an understanding that there's a deficit. Now, you work in a neurosurgeon's office, is that correct? Well, Dr. Puente, this is all a waste of time. And honestly, I think the easiest thing to do is let's go ahead and do a brain scan. What's the problem with an MRI or a CT scan?
Well, one of them might not show you as much as the other.
Okay, all right, so let's take a few moments since we're talking about both of them. CT scan is really good. It's a computerized axial tomography. Some people call it CT or CAT scan. And they're really relatively inexpensive, and they're really great for looking for masses like tumors or a good old blood spill or something like that. But they're not very sophisticated. They're kind of like gross. So if you got time, you got some cash, you throw in a magnetic resonance imaging or MRI. And there, and by the way, we're now doing T2s. And the beauty of those is that you can go deeper. You can look at white matter, not just white, not only gray, but also white matter. And that way, you can determine other kind of disorders. Like, for example, you can't find multiple sclerosis on a CT scan, but you can find it on an MRI, okay? So sometimes you might do a CT scan when you go in the hospital right away, make sure there's nothing really bad or emergent, and then afterwards, you know, if you need some more affinity or definition, then you do an MRI. But here's the problem with those. The problem with those is that they're often just tell you structurally what's wrong. They don't tell you the functional capacity. So the neuropsych stuff tells you functionally what's the matter, whereas the neuroradiological study gives you a very gross view of the structural. And I'm going to posit to you as we discuss these two that you really need both to be able to understand what's going on. So you need a view of the brain, if at all possible, and you need understanding of the function of the brain, because the two themselves are just, one alone is not good enough, 2 together is even better. But sometimes, sadly enough, they don't match. The CT doesn't show anything, and the neuropsych is all over the place. as I remember telling a neurologist I worked with at Wilmington Health, he goes, "Hey, guess what? I got an MRI of the multiple sclerosis on patient X, Y, and Z, and it's clean." And I said, "Well, what the heck? My neuropsych is all over the place. It's all messy. Well, what's up with this?" And he goes, "That's your job. My job is to see if there's anything structural that I can see. Your job is to find out functionally what's the matter with the patient." And that's what the two combined really makes it for a more powerful understanding of how we do this. So does that make sense? You
Yeah,
have a
it's like
question?
kind of like when I was a nurse, I remember like there was an older woman who came in who a lot of people just thought, oh, she must have dementia, but actually she had delirium because she had a really bad UTI that led to sepsis, and so she got confusion, and she had bad memory, she couldn't really remember who she was, stuff like that, and it was just a really bad case of infection in her blood.
Well,
And so without
now
seeing the, you know,
you
that
gotta
part-
see the whole thing.
Yeah.
Now let's go, you also brought up an interesting point. So we're adding, in this particular case, we got the functional part, which is the neuropsych testing, the structure part with the MRI and CT scan, but it's more complicated than that. Let's continue our discussion down the theoretical angle. What are some of the variables? For example, sometimes the disorder is static, and sometimes it's moving. It's really dynamic. For example, in the case of a brain injury, you're functioning really fine, and all of a sudden something happens and you drop, and you, for example, have a loss of consciousness. I just finished working on a case this afternoon where a child was literally, I don't know how she survived, a pickup truck ran over her head. So in that case, she was functioning, she was playing, and then just like that, a truck runs over her head, and then she goes into, basically loses consciousness. So essentially, you see something like quick. In the case of, for example, degenerative disorders like Parkinson's, I don't know where the heck I was today, and where there was a patient walking, and oh yeah, it was at the urologist's office, taking my wife there, and this guy was walking like shuffling. Well, if you look at the history of that guy, whoever he was, at one point he was fine, and he was less fine, and he was less. And this is how it goes. So I don't know if we have this. So basically, I've told you so far that we're comparing A to B, like I'm saying earlier. We're comparing you to the performance on other people who have brain injury. But you're functioning like this, and you have a TBI, and you drop down. Or in the case of a degenerative disorder like Alzheimer's, you're functioning like this, and you start going slow. Now, what's really beautiful here is, and we'll call this time, okay? If you're looking at the case of a TBI, then after you recover consciousness, you have an S-shaped curve that looks like something like this, okay? And in the case of an Alzheimer's or MS or anything like that, you're functioning fine, and then you start having a reduction. The difference is the S-shaped curve is the opposite. So you have one that goes up and the other one that goes down. The trick into both is understanding that the S-curve goes up in some kind of disorders, the S-curve goes down in other kinds of disorders. And here's the bitch about the ones that go up. In the case of a TBI, after 6 to 12 months, and we'll talk more in detail about it, after 6 to 12 months, the darn thing stops getting better. And what you're doing now is like, uh-oh, this ain't improving. Okay, I used to be like this, now I'm like this. So the difference between the two, we'll call the change score, is essentially the difference between what we call pre-morbid level of functioning to, if you want to get technical, to what we call a morbid state of functioning. And that difference is what we would call brain damage. Are you with me? So, in the case of the little girl today, it was really a tough situation because the attorney that I was talking to said, he asked me this question: what was her functional ability before she got run over by the pickup truck? Well, did I know this girl before she got run over? Nope. And guess what? Her mom and dad are undocumented and have almost no schooling. So I'm going to guess that maybe it wasn't particularly high. But it turns out that she had been doing really well in school and had learned English. So conceivably, she could have been maybe normal or less than normal. I don't know that. But I'm going to take a stab, and I'm going to assume this is her premorbid, this is where she is, it's been a year since the accident, and that difference is what we'll call the change or the injury itself. Okay? Now, in the case of Alzheimer's, or multiple sclerosis, or Parkinson's, or anything like that, and we'll talk about all of them later on. So I am functioning here, okay, and now I've been called in to address this. And the question is there much difference? Well, I'll give you an example. I remember doing a very simple test on a patient. He lived in Landfall, and I remember going to his house because I knew him, and I couldn't get him to come to my office. So I remember asking him, hey, what's your name? Because I forgot. Secretary didn't tell me who I was supposed to visit this afternoon. Well, I knew who it was. I knew him before he had actually gotten Alzheimer's. So it was like a stupid question. And the guy said, hell of a good question. I'll get back to you on that. Because he had forgotten his name. Okay? Obviously, the difference between forgetting your name and running a company of significance, which he had done, to now was a lot. So in this case, the change is really, really big deal. When we're finishing what we're doing, what we're looking for is the change of where we're at to the anticipated, estimated premorbid level of functioning. Now, sometimes I'm lucky. Sometimes I'm lucky, and we'll talk about it. Sometimes I know the patient, or maybe I tested them. And honestly, when that happens, I get super excited. Somebody comes in, they're 55, they're going, I can't remember worth beans. And I test them, and I say, look, you just got divorced, you got 5 kids, you're blah, 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 you're fine. There's nothing going on. And then I get to see them at 70. And this time, they really have a memory disorder. Well, then I'm good to go, because this hypothetical premorbid is no longer hypothetical. It is real. Okay, now, before I continue, maybe you can help me out. If you don't have any records of somebody's premorbid level of functioning, what are some of the things that might give you an idea that they had at one point done well in their life or not so well? And we're going to start with the filmmaker. Colby,
Hello.
What do you think?
Education?
Education is the best one. If you have no other option, go with education. And if you don't know, maybe the parents' education, because that's a good one. Anything else?
Career.
Career? What do you do for a living? Okay, for sure. Health status? Health status might be good. Family, everybody else in the family has a terminal degree. And, of some sort. They all have masters or doctorate. Okay, we don't know for sure, but you probably come from good stock, so therefore you're probably pretty good. So what you're trying to do is you're trying to get a history. Now, the best way to get history is our records, which we'll talk about, But if you can't, just take an estimate through interviews and we'll go into some detail. So are you getting an idea? How is it that we discover how someone may be functioning? Yeah, we can take an MRI, we can take a CT, but in reality it's doing these things in a scientific, empirical way, in such a manner that you are pretty accurate to about a 95% degree that you're on the money. That's what neuropsych is all about. Okay?
Do brain patients with like that had accidents like on the left graph, do they usually recover significantly? Pretty
So,
significant recovery.
yeah, well, it just depends. You know, and we'll talk about it in a lot more detail. So, for example, since you asked, you're asking this question without meaning to. What are the variables that influence the movement of that curve?
Yeah.
Up or down? Either way, okay? How am I going to get that curve to go as high as possible? In other words, here's what I think about. What can I do to push that curve to go up and up and up? Or, if we're talking about going down, what can I do to push that curve so instead of that trajectory, I have a slower trajectory? You with me? So what are the variables, or what are the things that can be done? Well, it depends. So for example, if I have someone with no education, a tremendous injury, they had a loss of consciousness for a long time, and they've been drinking, there's no family support, the insurance is horrible, I think the best I can do is, since I'm Catholic, is give them a rosary. They're in trouble, okay? I had a patient now, many years ago. It was really sad, one of the most difficult, unpleasant exchanges I ever had. He had dementia, secondary to AIDS, and he said that was in the days where being gay was really, really bad, and his family had disowned him, his lover had left him, he had no money, no insurance, and he was thinking about killing himself. And it's like, I'm going to die anyway, might as well just die while I have some idea that I'm living. Well, what can you say under these circumstances? That's really a terrible circumstance to be in. Now, other times, you got people that have advanced degrees, have great insurance, a lot of social support, they're mentally healthy, they're driven, they want to get better, you know, then those curves are affected, okay? So, sometimes the curves, you kind of like look at them and you go, oh my God, there's no chance in hell. They're really in trouble. Had an older woman that was living by herself in a bad section of town, and she had no children and nobody looked up after her. I think she was basically doomed. Then I have other situations where the opposite is true, you know. So it just depends. But the shape of the curve is almost always S, one way versus the other. And the question is, what can you do, and we'll talk about it towards the end of the semester, to either increase the curve to go up or make sure that you can do something so the curve doesn't go down. Now, it's important, in case you didn't catch it. If I test the patient here, right after the brain injury, it's going to be a hell of a lot different than if I test them 2 years after. Because the recovery, as we'll talk about, the recovery for brain injury is about 6 to 12 months. The point of Alzheimer's, from diagnosis to death, is roughly 6 to 8 years. So if I'm catching someone at the beginning, as I remember, I had a surgeon that I tested him, and I started testing him in his 50s. And he goes, I want you to tell my partners when I can't think anymore. Don't tell me, tell them. So if I catch him in his 50s, and he's making $500,000, and he's a great surgeon, it's not a whole hell of a lot I'm going to see. If I see him at maybe at 65, when he's starting to have some memory problems, it might be maybe here. At 70, maybe here. At 75, might be here. Okay? So the time that I see him post-injury or at a pre-morbid level that was functional, it's gonna determine exactly where I find it. Now, if I am lucky as hell, like I told you, I may know the pre-morbid, but another way to get lucky is that you are able to test them at different times. So for example, I have a head injury, I see them in the hospital soon after they come out of a coma, I see them 6 months after they've got some intervention, I see them 12 months when they're trying to get back into a job setting, and I see them maybe 3 to 5 years afterwards. Well, if I can do that, the more data points I have, the better the curve that I can draw. If I only have one data point, I'm going to do a lot of estimating. But if I have several data points, I'm going to be in really, really, really good shape. So the goal is, where do I test them, and how many data points can I get? I just finished talking to the attorneys involved in this little girl's case, and I said, if you can't solve the problem right away, if the defense or defense for the insurance company starts throwing a lot of balls at you, slowing down the case, awesome. Let me see her again in a year. And then I can be really sure where this little girl is going to be, okay? So the more data points I have, the better. It's critical, otherwise I'm just doing rough estimates. So do you kind of see the background of how is it that we think, okay? Do you appreciate also how I don't want to just do one test of memory, okay? Now I'm going to go into a lot of detail, and not too much today, but next couple of times, that all things being equal, depending how you look at it, there may be about 10 or 15 domains that we measure. Let's talk a little bit about what some of those domains might be, okay? And I'm going to take the easiest one, and you guys are going to have to help me with the harder ones, because I'm not firing on all cylinders. So, okay, the first one is orientation. Who am I, where am I, that kind of thing. Can you give me others?
Memory, short-term memory.
Okay. Now I'm gonna sort of infuse some theory. I'm gonna use the approach that Luria presented. And I don't think, did we talk about Luria very much? I don't think so. Okay. Alexander Luria was a neuropsychologist that some people believe was the father of modern day neuropsychology. He's in Moscow, and I've got the opportunity to go there and for them to come here, so I have a better understanding than average of what is it that his thinking was. His approach to all this is that even though there may be 10 or 15 domains that one could measure to get a full glimpse of what is going on in someone's head, the way that he thinks about it is that the brain itself is sort of broken down into maybe sort of 3 parts. Sort of the base part, the middle part, and then the top part. The base part is really one involving very simple stuff like orientation, like who are you, where are you, what day is it, date, things of that nature. Very, very simple. Most of us are in the ballpark on that. Very often, we'll talk more about it later on, people sometimes use something called Glasgow Coma Scale, and they measure like, are you awake? Do you respond to, getting a pinprick and so forth? This little person that I saw, when she was run over by a truck and the EMT showed up, she had a score of 3 out of 15. After 3, you basically were dead. So she was just basically breathing and responded a little bit to pain stimuli. That's very, very simple. A little bit higher involves things like attention, motor functions, sensory functions. And then at the highest level are other things like, can you tell me some? Memory. What else?
In terms of this, or just in general?
Cognitive functioning. Problem solving.
Yeah, like more like higher order thinking.
Yes. Some people call it higher order. Other people call it executive functioning. So understanding problems, planning, organizing, engaging in a goal-oriented behavior, things of that nature. Academic abilities, intellectual abilities, are all things that maybe other animals don't have much, or certainly not as much as we do. Okay? So in many ways, if you were a neurosurgeon or a neurologist, you're going to end up doing some of this basic stuff. If you're a neurologist and really into this, you might do some of this middle stuff, but this complex stuff involving executive functions, memory and the like, they don't really do very much. In fact, I'll tell you a case involving myself with a guy that used to be in Wilmington. His name is Dr. Wilfong, Robert Wilfong. Have you heard that name? Yeah. Dr. Wilfong used to be a neurosurgeon up in New Bern, and I actually worked on a case that he had seen the patient. This guy was, and I'll tell you his name because he's part of the public record. His last name was Horn, and he had a tree fall on his head, and it drove him into the ground. Not only did it drive him into the ground, but it actually popped his teeth out and messed up some of his vertebrae. But for whatever reason, when they took him to the hospital, he was still conscious, and Dr. Wilfong asked him, "Who are you?" And he said, "My name is Horn, and where are you?" "I'm at the hospital," and so forth, so on. So he said, "Fine, you're good to go. You don't need any surgery." There was the CT that showed no blood, so off he went to the races, so to speak. Well, he drove those logging trucks, which I don't know how you feel about those logging trucks, but I'm always wondering when those damn logs are going to come out and hit my car. Well, this guy would go to these country roads, and he wouldn't stop at stop signs. He kind of like slowed down. And then every so often when people got in his way, he would honk or sort of get close to their rear, that kind of thing. So people started complaining that he was being a dangerous driver. Well, a dangerous driver and a logging truck driver, that's just not that good. So he was sent to me, and it turns out, yes, he did know who he was, but his ability to pay attention wasn't very good. His memory was shot, and he couldn't inhibit his emotions at all. He was flying off the handle a ton. So we went and submitted this, and the state of North Carolina said, Dr. Wilfong is a real doctor. Dr. Puente is, after all, Dr. Puente. Not only is he short, but he's bald, and he's foreign. So, no, that was bad. But he said, I wasn't a real doctor. So actually, I got APA to be involved. We did an amicus brief. We filed the suit, went to the state Supreme Court, and it was overturned. Because here's what I said. I can't read CT scans. MRIs are outside my area of expertise. I let Dr. Wilfong do that. I can't cut. Don't ask me to cut. But Dr. Wilfong has no idea about higher order functions. That's my job. So if you want to talk about whether he's impaired neurosurgically, ask him. If you want to ask whether he's impaired in terms of his memory, his problem solving, his ability to inhibit, ask me. And we won. And that began, as we'll talk about in the next few minutes, the beginning of what we call forensic neuropsychology. And that's because I stuck with this area, with these domains, and he and other neurosurgeons and neurologists tend to stick with the more basic ones. Now, is that bad? No, I need him. In many ways, like the neurosurgeon needs me, I need them. Now, here's a quick side comment. It turns out I never, ever have had difficulties with neurosurgeons or neurologists. Professionally, we work well together, and historically, the neurological community, neurosurgical community, neuropsychological community have gotten along. This is not the case with psychiatrists and clinical psychologists. And why is that? Since you smiled, we'll ask you.
No.
Yeah, have you guys heard that? That there's between psychiatrists and psychologists? Why do you think? Well, I think it's because we're smarter than psychiatrists.
They have the ability to prescribe.
Well, actually, we also, in certain circumstances, do too. But you have, in few states and with some training, but very infrequent.
Yeah. Well, psychiatrists, they have their medical degrees, so they're usually, I feel like people probably put more weight into what they say.
Yes, and I always think it's also awesome that the first time they get any courses about human behavior is after they finish their psychiatry residency, or when they start the psychiatry residency. When's the first time you took a course about psychology? And then, did you take any as a sophomore? And as a junior, and as a senior, did you take any psychology courses when you were in
Just
grad
a
school?
little.
A few. The first time a psychiatrist gets a course on behavior is when they do the residency. So, I don't think they're well trained relative to us, but the point is really not that. The point is this, that they're really, in many ways, fighting for the same patient, doing the same kinds of things. Whereas, I can't cut. Dr. Alsina can't. I can't read MRIs, he can't. He can't do neuropsych testing, I can. I need him, he needs me. It's a symbiote. We don't fight. We're very much, we're working together to achieve the same goal. Whereas very often with psychiatrists and psychologists, it's not the case. Which is really sad, because in reality, most psychiatrists, this is slightly a deviation, they're mostly into medicines, and most psychologists are mostly into psychotherapy. And if you read the literature, having both together improve the efficacy versus just one or the other. And just to add a piece of information of no value, but could be useful in trivial pursuit, who ends up prescribing most antidepressants of all kinds of physicians?
Your general family doctor.
General family and
I was gonna
OBGYN.
say OBGYN.
Yeah, so it ain't psychiatry. So the people that are using Valium and so forth are prescribed, or Zoloft, they're prescribed that by other people, not psychiatrists, which is not particularly a wise thing. But that's for a topic for another day, and maybe pizza that Christy will get us. You gonna get us a pizza?
Sure.
Christy, okay, very good, okay. So, what we're doing is we're doing a series of comparisons on each of these domains, which what I thought, or I think, was a pre-morbid level of functioning to that day that I'm evaluating the patient. And where's the difference, and where is it going? Is it going up? Is the status quo, it ain't gonna improve, or is it going down? Sometimes I'm in a situation, I'm in trouble over here. For example, we'll talk again some other time in more detail. They're basically a simple and more common used neuropsych test. It's called a mini mental status exam. It's 15 questions. Who are you? Where are you? That kind of stuff. And I bet you Dr. Alsina does that.
I'm not under Dr. Alsina, but something interesting is I was with a doctor in PA at the hospital last week, and there was an ER patient who was visiting. He'd administered the test, and it was really interesting because he said, "Do you know your name?" He answered correctly. He said, "Do you know where you are?" He said, "Yes." He said, "Where?" "At the hospital." And then he said, "Do you know what day it is?" And he paused for a few minutes, and then he said, "The hospital." And then he said, "Do you know what this is?" And it was a watch. And he's like, "It's a watch." And then he said, "Do you remember like what year it is?" And he said, "The hospital." So that was
Okay.
interesting.
See, now, if you got them all right, he should get 15 out of 15. Okay, or maybe say 30 out of 30, because most mini mental status exams are 30 out of 30, or 30 questions. I started this patient, when I first saw her, she had like a 29, and then little by little it's 28. And after about 5 years, I would see her every so often, it was 0. And then 0, and 0, and I was like, finally told the husband, look, I've seen her now like 5 times, the score of the mini mental is 0. She can't talk. I'm really, really sorry, but there's nothing I can do for her. I think it's time for you to realize that your wife has pretty much has died, and you need to start grieving, because he goes like, there must be some medicine that we could try. Let's try this medicine. Let's try that medicine. When you got 0s over a period of time, and the line is like flat as a pancake, and you're like slightly above death, what can you do? You have to adapt, okay? So essentially what we're trying to do is get these scores to get a trajectory, get a best understanding of which way we're going. Hopefully is up, and if it's going down, how slow can we go for each of these domains? Do you appreciate that? So I do it for attention. I do it for memory. I do it for problem solving. I do it for intelligence. And then, once I have that, I put them all together to try and get a composite picture. And if I know something about the disorder, I know, for example, in Alzheimer's, that you may have motor function problems, you might have difficulties in word finding, and you might have difficulties in memory. And if you have difficulties in memory, if I help you, if I cue you, you'll improve. So, you know what? If I give you like certain ideas, maybe to kind of prime the pump, then maybe you can get better. You don't necessarily see that in Parkinson's. So if I get some improvement, then it's probably not Parkinson's, it's probably Alzheimer's. So you get the drift? Because not all of the domains are going to be impaired. And if all the domains are impaired, that happened to me recently where we finished testing a patient and everything was like low, 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 low. Well, I think we're at the end of the road. This is really, really, really bad. Okay?
So if you test a patient and they're not at the end of the road, what kind of interventions do you use?
Oh, that's the end of the semester.
Okay.
Well, it depends. So, for example, and I'm just going real far ahead of the game. If I find that the person has vascular dementia, get them on low-dose aspirin, okay, because that will increase blood flow. If they have good old Alzheimer's, then maybe get an anti-Alzheimer's drug, okay? And maybe get them to do more physical activity, more mental activity, but we'll talk about it. One thing is, I don't ever give up on patients, even if they're at the end, unless they don't know who they are, that they don't know who I am, they don't know what we're doing. Then at that point, it's like, why are we doing this? So, okay? Do you have an idea then what we're doing? We're trying to get these measurements across all these different domains, looking at the patterns for each of those domains and comparing those patterns to other disorders, like the ones we're going to talk about this semester. Are you with me?
Yeah.
Okay, so what time do we have? Okay, it's been plus or minus almost an hour. Okay, so why don't we do this? Why don't we take a 5-minute break, and then we'll then come back and talk about the practice and profession of neuropsychology. Sound like a game plan?